Well, greetings, students. Dr. Matroka here to talk about cholesterol-lowering drugs today. Well, I want to start out from this quote from Sir William Osler. Longevity is a vascular question, and just really try to make sure everyone understands that your blood vessels, the quality and integrity of your blood vessels really, to a large extent, drive your overall health. And cholesterol is a major contributor to damage of your blood vessels. So that's why we're going to talk about it. But on the other hand, keep in mind that cholesterol is a very important compound. It's an endogenous molecule. It's required for the synthesis of steroid hormones and also an important component of membranes. But too high a level definitely damages the vasculature. So what is too high a level? And this little diagram shows you in a very simple way the one number that I'd like you to keep in mind, okay? And we're going to talk about what LDL cholesterol is in a minute, but it's something that comes out of a so-called blood lipid panel if you have your blood tested. And it's a simple thing to remember. You want that LDL cholesterol to be under 100, okay? And higher levels than that are really put you at risk for cardiovascular disease. So you can look at the learning objectives on your own. And I wanted to just briefly show you how important these drugs are in relationship to the most prescribed 200. And you can see now I pulled out of those most prescribed 200 those drugs that are used for controlling blood lipid levels. And you can see that the statins, whoa, are right on top. Okay, statin, and then here's another statin. And there are a few other things thrown in there. The only other one we're going to talk about that's on this list is ezetimibe, which is a cholesterol absorption blocker. But statins are, our go-to drug for reducing blood cholesterol levels. So what is the problem with having excess blood cholesterol? So this diagram, I think, does a nice job of showing the consequences, which is atherosclerosis, okay, which is a buildup of cholesterol essentially in the lining of the blood vessels. So why I like this diagram is it does a nice job of showing you actually what happens. It's not, the garden hose analogy really is not good. You can't come in and rotor-rooter excess plaque cholesterol in the way so many people think of it. What happens is cholesterol really kind of sneaks its way underneath this endothelial inner lining of the blood vessel and gets enmeshed in the musculature, and then the body sends macrophages to try to eliminate the cholesterol, but it doesn't work. And what you end up is having it's called foam cells, kind of a big collection of lipids and debris here, that if it gets big enough, if this plaque gets big enough, it can basically occlude the lumen of the blood vessel so that it restricts the flow of blood. And that of course is what you hear about in people who have angina. Okay, there's insufficient flow of blood and they feel pain in their heart. I'm talking about an artery here that feeds, that's a coronary artery in this case. But the more frequent problem is that this plaque ruptures, that it would just break open through this fibrous cap, and that can happen spontaneously without any particular reason. That can happen, and then this the entire contents of this plaque travels through the blood vessel, and it can form a thrombus, right? It can form a clot. If it's a clot in the heart, you get a heart attack. If it's a clot in the brain, you get a stroke. So those are the two ways that atherosclerosis can contribute to cardiovascular disease. Now, what what are some of the risk factors for atherosclerosis? I just wanted to go over this real quickly with you. One, of course, is excess LDL, and we'll call that excess cholesterol. All right, and we're going to be talking about that. Another is smoking, which generates a lot of nasty free radicals, which damage the blood vessels. Diabetes, high glucose levels, which glycate or covalently bind to components of the blood vessels. High blood pressure, which basically forces the cholesterol through the intimal lining into the musculature of the blood vessels. Okay, and then family history, which is essentially saying genetics and age. Okay, the damage, the plaques generally tend to accumulate with age. So all those factors work together, and we're just talking about having high cholesterol levels. And just keep in mind, though, that it's just one component. All right. What are good and bad cholesterol? Basically you have the same cholesterol molecule, but kind of packaged in a different protein called an apoprotein. Okay, so the cholesterol molecules that are packaged in one kind of apoprotein, which are called high density lipid proteins, they tend to reflect cholesterol that's being drawn out of tissues, where low density lipid proteins are cholesterol packaged in a different kind of protein, where they tend to deposit cholesterol into tissues and into blood vessels. So those are not good. But these are two forms. I want to be careful here. The cholesterol is the same, but packaged differently. And then, of course, we have other kind of blood lipids, which are essentially triglycerides that can contribute to cardiovascular disease to a lesser extent, but we're not going to be talking about those here. Is there a chemical difference between the cholesterol and HDL and LDL? No. And again, our objective is to reduce total cholesterol. Well, where does cholesterol in the body come from? And there are two ways that we basically acquire cholesterol in the blood. One is by synthesis, right? Cholesterol can be made in the liver from other precursor molecules. The other is that you can absorb actual cholesterol molecules themselves, okay, from the diet. And then the last thing is that you should be aware that cholesterol can be eliminated. The body has a very exquisite way of trying to regulate cholesterol levels. Not too much, not too little. But when the liver can not only make cholesterol, it can package it, package it in a way that it can be excreted in the bile here, okay, in the bile, and then end up being eliminated in the feces. Now, the synthesis of cholesterol in the body comes from a simple molecule called acetate. Okay, so all the carbons in cholesterol can be traced back to acetate. And so I asked the question, where does acetate come from as far as our foods? It comes from all different types of foods. You can see that carbohydrates, proteins, fats, all can contribute to acetate. So as long as we have this acetate, we can make cholesterol. So it's just something to keep in mind, because people often associate certain foods with buildup of cholesterol. Yes, you can get cholesterol from the diet, but it can be made in the body from virtually any food component. So let's start talking about statin drugs. Okay, these are also called HMG-CoA reductase inhibitors for reasons that should become clear. And now when we're talking about cholesterol biosynthesis, okay, cholesterol biosynthesis, again, it starts out with the simple molecule acetate, and it goes through all these steps. Look at here, 20 steps just in conversion linosterol to cholesterol. But all these steps end up leading to cholesterol. The important thing for us is that the HMG-CoA reductase part here is the rate limiting step. Okay, Once this occurs, everything else you could think of as being downhill or spontaneous. So this is the step that is addressed by the statins, are inhibited by the statins. Okay, this part on the left is just showing you what we've already talked about, the pathway for cholesterol synthesis and where statins intervene. But on the right here, this is interesting. It shows you the the product of HMG-CoA reductase, mevalonic acid, and how similar that is in structure to the statins. And just note that just like mevalonic acid has an acid, is it what we call a hydroxy acid, this is also a hydroxy acid, okay, the statins. So the statins are all the same except for these different, slightly different appendages on the lower part of the molecule, this lipid part of the molecule, which helps the drug get where it needs to be. Well, there are currently 7 statins on the market, which you may think is more than we need. To be honest with you, a lot of the pharmas developed their own statin because they wanted to get a slice of this huge economic pie. But the fact of the matter is that they do differ with respect to physicochemical properties, PK, potency, and their drug-drug interaction potential. Okay, so there really are important differences between them. Lovastatin was the first, and it was derived from natural products. So this is not, statins are not something that the brilliant medicinal chemists came and figured out based on the properties of HMG-CoA reductase. It was kind of done backwards. First of all, they found the natural product and then kind of back calculated how it was working and how similar compounds could be made. Let's take a look at statin potency between the various marketed drugs. So if we look at a 40 milligram dose of the various statins, you see that the reduction in LDL is, wow, 65% or so for rosuvastatin, whereas for pravastatin here, it's pretty darn, oh, that's fluvastatin. It's pretty low. It's only about 20%. So there's can be quite a bit of difference between the potency. But as I say, you may not always want to go for the most potent one because there may be some characteristic that precludes its use in a particular individual. Now, something else that's unusual about HMG-CoA reductase inhibitors is that it's been found that their benefit in reducing morbidity and mortality is not necessarily related to the extent that they reduce LDL. It's one of these strange phenomenon. So people have, although reduction in LDL is very important, don't misunderstand, but there seem to be other things going on. And nobody knows exactly what those other things are. These are some possibilities, but the bottom line is that there seems to be a reduction in inflammation. And that can be measured by looking at C-reactive protein in the blood. So that seems to be possibly the other factor. Pleiotropic action just means many components to the action. So overall, the absorption of HMG, the statins, let's call them statins, is high, but the bioavailability is low. I hope that triggers something in your mind. Why might that happen? And I can tell you, if you haven't guessed, it's high first-pass metabolism. Okay, half-life varies widely, and elimination pattern really differs between the different statins. Okay, we can't necessarily put them all in one bucket, as we've done in the past for CCBs and ACE inhibitors. You can't necessarily do that here. But one group I want you to keep in mind is atorvastatin, lovastatin, and simvastatin. I call these ALS statins. Those are eliminated primarily by CYP3A4 mediated metabolism. So I'm just showing here the different statins. You can see the bioavailability is very low for most of these. Elimination half-life varies widely. So atorvastatin could be given once a day, lovastatin maybe 2 or 3 times a day. And I have the question here, why do statins work so well when they have such low bioavailability? Well, one theory is that, remember, things that have low, high first pass metabolism, which is many of these drugs, many of those compounds, what it means is that the liver sees them, but organs after the liver don't get to see the drug because it's been cleared by the liver. All right, so the liver itself gets to see whatever is absorbed from the intestine. All right, so I hope that makes sense to you. Even though the liver may be breaking down or eliminating through excretion in bile the various statins, the liver is being exposed to high levels of the actual statin. And this diagram is just showing you the different ways that statins can be eliminated. As I say, the ALS is primarily eliminated by CYP3A4 mediated metabolism. The other ones, let's just say, have a mixture. Part metabolism, part renal, part excretion in the bile. It's kind of a mix, all right? So the 3 we want to be concerned about in terms of drug-drug interactions are the ALS. So what are those drug interactions? Well, primarily concerned about inhibitors, CYP3A4 inhibitors, and this is just a list of them. Typical inhibitors that really can send levels of those 3 statins through the roof if you're taking them concomitantly. And also grapefruit juice, that's a natural product inhibitor of CYP3A4. Now, in terms of, I make a bit of an issue about this, so bear with me. The adverse effects of statins. These are very well tolerated drugs in general, and I know there's a lot of hype about them causing problems, but generally they don't. Some people, a considerable number, maybe 10%, do experience initial muscle pain, but that goes away after you've taken the drugs a few times. Now, this is serious rhabdomyolysis. A very small percent, maybe 1 in 1,000 patients, have this problem where the muscle tissue actually breaks down and the components build up in the kidney, causing renal failure. Okay, now it's hard to really pin down what causes this, but because it's only 1 out of 1,000 patients, but it's been found that most of the time people who have experienced rhabdomyolysis with statins are taking one of these ALS, one of them that's a substrate for CYP3A4 with a CYP3A4 inhibitor. Okay. And you can see here, I'm just kind of the same thing I've already mentioned, is that statins harms tend to be overestimated. I would say that your risk of running into trouble by having chronically high cholesterol, LDL levels, is much greater than the harm in taking a statin. I'm taking rosuvastatin myself. Now, there's also a new kid on the block that I want to talk about, getting away from the statins here, and these are the two drugs here. I'm not even going to try to say them, but they're PCSK9 inhibitors. All right. And these are extremely effective. They reduce LDL levels by at least 70%. Tremendous reduction in LDL. And what they do, I'm going to show you in another slide, it's a little complicated, is they prevent PCSK9 induced breakdown of hepatic receptors of LDL endocytosis. All right. And these are monoclonal antibodies, so they're proteins that are given by injection every couple of weeks. They don't really have many adverse effects, but they're very expensive. And they're usually just restricted to people who, just can't, the statins aren't working or are causing a lot of trouble. So here is the diagram explaining how these work. Now, this is unusual because we're starting out with a discussion where the inhibitor is present. So this is saying if you have here's the PCSK9 biological molecule, this is what's endogenous, right? And it's taken out of the picture by the inhibitor. So this is now not actually operating. The PCSK9 is not operating because the inhibitor is present. So what happens in that case? Well, LDL cholesterol, okay, which is in the blood here, passing through this liver cell, LDL binds to a LDL receptor, and that's kind of invaginated to make an endosome inside the liver cell. And then the endosome opens up, lets out the LDL cholesterol, which is excreted in the bile, and the receptor itself remains intact and kind of rejoins the cell membrane. All right, so that's when the inhibitor is present. Now, this is kind of hard to understand, but it's the fact of the matter. When that inhibitor is not there, like in you and me, people not taking the drug, there is this PCSK9 molecule in the body, which kind of binds to the LDL receptor, LDL cholesterol complex, okay? So that whole complex is taken in, and because that PCSK9 molecule is there, it directs the endosome to go to the lysosome and be degraded. So now the LDL receptor is gone, and you have to synthesize new receptors in order to absorb more LDL cholesterol. So if you hopefully you could see that when the inhibitor is there, you get more uptake of LDL cholesterol by the hepatocytes and excretion. So the way these inhibitors were discovered was by serendipity, and essentially it was found that there are some people who as shown here in this slide, who had really they just had there were very few people who had high levels of they took these people who had really low levels of cholesterol and compared them to people who have high levels or just normal levels, and found that there's a mutation in it was tracked down to this protein PCSK9. So people who have that mutation seem to have very low levels of LDL. Check this out, coronary heart disease. People who don't have the mutation have, this incidence of coronary disease, right? People who have the mutation hardly have any coronary heart disease. Isn't that the strangest thing? That actually, at least, in terms of cardiovascular disease, it confers a real advantage to have that mutated form of the protein. But anyway, that was discovered, and based on that, they were able to develop drugs. So the last type of drug I want to go over are these cholesterol absorption inhibitors. Okay. We talked about statins, they reduce synthesis. We talked about PCSK9 inhibitors, they reduce or they increase elimination. Now we're talking about a drug that blocks absorption, and there's really only one, so we often just refer to the actual drug name as ezetimibe. And the way this works is that it blocks, basically believe it or not, there's a transporter in the intestine that picks up cholesterol, okay, and it blocks that transport. It's just, let's keep it simple like that, okay. And ezetimibe is useful because it's a different mechanism, so it can act in principle synergistically with other hypolipidemic drugs. So very common for people who are not, having good results with diet, lifestyle, statins, to pick up ezetimibe as well. Oh, and by the way, I'm sorry to digress a little bit here, but oh, uh, but but lifestyle changes in diet are obviously the first thing to do to get your cholesterol down. But quite often, it's not enough, and people should take the drugs in order to get their levels down. Okay, so back to ezetimibe administered to patients who, either have, a modest level or need to take something together with the statin. Okay, um, very, very, very mild adverse effect. Really nothing to speak of. And just to kind of conclude this, the to review here. First of all, in terms of mechanism, you should be aware. We talked about this several times. Statins reduce cholesterol, LDL cholesterol, by blocking synthesis. Ezetimibe decreases intestinal absorption. PCSK9 inhibitors increase degradation or increase elimination of LDL cholesterol. Okay. Now, the extent to which they work, or you might say their efficacy, is ezetimibe is the least. Statins are pretty darn good, especially the high potency statins, and PCSK9 are just unbelievable, the extent that they can reduce cholesterol. All right, my young friends, I think, let me just double check. I think that's it for this set of slides. I hope everything made sense. If not, send me an email and we'll talk about it. Bye-bye.